The broadcast is now starting. All attendees are in listen-only mode.
Well, welcome everyone. This is an important subject. We have a lot of people registered for this webinar tonight. I want to thank my good friend Mark Murphy for suggesting that we do this on a very important subject that's, I would say not cheery, but we're going to try to find the best ways to navigate through all the changing times. I heard my wife say that she read this somewhere, or someone texted her this. Last week was the longest month of my life, and I think that just sums up what we've all been going through. And I think what our goal here tonight is to very seriously talk about what we can and can't do as dentists, all the restrictions that we have, how we can work around some of these things through telemedicine. Understand we actually have a guest with us. I'll introduce everyone right now. I guess Dr. John Remmers, a man who needs no introduction, is decided to join us as well. So that wasn't on your invite. He's going to talk about CPAP and some of the controversy now with the coronavirus. I have my good friend Dr. Mark Murphy, lead clinical advisor for Prosomnus, whose idea was to put this together, and who's become kind of the, at least my go-to person to understand what's going on with this coronavirus. He's done a lot of research. And then we have Dr. Jagdeep Bijwadia. He's a physician who's in sleep medicine, has sleep centers, and we did a webinar not too long ago about telemedicine. I think bringing you back on is a fantastic idea here today. So I'm not going to talk much today. I'm Dr. Guy Yatros from Dental Sleep Solutions, and we really just want to make this very informative. If you have questions, you can type them in the question box. For some reason, I can't personally see those, but I think everybody else can, and we'll either answer them verbally or type them in.
You're saying you can type them in, but we're not going to answer them?
No, we can. Oh, I see where it is. It's up here at the top, maybe. But anyway, if I don't figure that out, everyone else can see them, and we'll read them out loud and get to them. But we have, hundreds of people are going to be on this. It looks like we're pushing 200 people right now, so we can't unmute you. And so I'm going to start with Dr. Remmers. You were going to start off everything with us, and thank you, buddy. My good friend from Pankey in Kentucky, and known a long time. So thank you for taking the time to talk with all of us tonight.
Thank you, Guy. I'm John Remmers, and I'm Chief Medical.
Can you all hear John? Shoot.
Of participating here occurred when I was over last weekend, and I was browsing through the American Academy of Sleep Medicine website, and noticed that they said not only should the sleep physicians stop doing polysomnographic sleep tests, and maybe shouldn't be sending out home sleep apnea tests, but in fact, they raised the concern about starting people on CPAP. Normally, this is done through what we call a CPAP titration in the polysomnographic lab, and they said don't do any CPAP titrations. And well, I thought that was pretty interesting. And then again, it mentioned that maybe people who are on CPAP shouldn't be coming into your clinic and having the CPAP worked on in the clinic. They said dental sleep medicine approaches, oral appliances are still fine, but they kind of put up the blockade around CPAP. So I thought that was shocking and interesting, and I'm an old CPAP guy from way back, invented some along the ways in the past few years, and I'm, of course, very devoted to oral appliance therapy. So it's all become very interesting to me. I've spent the last 72 hours or so researching this subject, looking into it deeply. And here's what I'd like to tell you about what I've learned. The title of this is "The COVID Epidemic Raises Questions About CPAP and Treatment of Obstructive Sleep Apnea." Now, this is John speaking, not AASM or not any other physician. This is just my understanding from what I've learned. I certainly know that the virus, the novel coronavirus, is highly infectious, no doubt about that, and transmitted via airborne droplets. So number one there, that's a fact. Now, so we have to build on that fact. The next one is that CPAP exhaust flow. That's the bias flow that comes out of the CPAP appliance very near the mask, the interface, that the exhaust flow that's coming out carries droplets into the environment. Again, that's a fact. Exactly the size of the droplets and what's going on there isn't too clear, but that's another fact. And an inference from me, but I don't think too many people are going to doubt the next one, and that is that these droplets that are coming out, you can't see these droplets. They're about 10 micron, 5 micron in diameter. They probably contain fluid from the patient's airway. So now we have this highly infectious virus that's in some people's airway and infecting their airway, and the droplets are coming out if you're using CPAP. So the question that comes up is, could CPAP spread the COVID-19? Could it be an agent for communicable disease and have other people get the disease from somebody that's got COVID-19 because that person's using CPAP? It's a question, and I can tell you right off that the answer is controversial. A lot of people are very interested, but I can just say right now that's a controversial issue, but it's enough of a concern that I think it's why the Sleep Academy suggested people do not begin CPAP for therapy of obstructive sleep apnea at the present time. So let me have the next slide, Guy.
Okay, just a second.
Yeah, no problem.
There you
go. So I say then that COVID-19 really may be changing how we treat sleep apnea. And as I mentioned, while the infectious aspect of CPAP is controversial, I don't think that that prevents us from changing the treatment in response to it. So I say that the American Academy of Sleep Medicine suggests no titration at the present time. They certainly mention that oral appliances are a frontline treatment and are acceptable. And it then dawns on me that dental sleep medicine may step up right here at the time of crisis and in the weeks and months that follows a peak in the incidence of COVID-19 might make an important contribution. So during and after the crisis, I think we need to certainly consider the possibility that our treatment is going to be become more important, needs to be more available because we don't have any infectious component to the oral appliance therapy. The next slide. So I'm going to call this the Matrix Plus Advantage, but I'm now touting the apparatus that I invented, but that is FDA approved and used a great deal in dental sleep medicine. It's called Matrix Plus. It's an in-home test. So it's a sleep test that will allow you to assess in advance, prognostically, beforehand, whether or not you're going to have a good therapeutic response to your oral appliance. That is to say, whether you're going to be able to eliminate the sleep apnea. And it can guide you in terms of how you want to configure your therapy, the amount of protrusion and other features that you might want to do. And actually, I think it may even increase the overall success rate with oral appliance therapy. Anyway, it certainly can inform you in advance about whether the therapy is going to efficaciously get rid of sleep apnea and do it efficiently. And that's the key here, is that we're interested in minimizing face-to-face contact between the patient and you, the dentist, or your staff. So the key thing is that by knowing in advance how to do the therapy, you can, in general, have one appliance, one visit just to fit the appliance, and that takes care of it. You can defer follow-up and so on, and still be sure that your patient is going to be well treated. This is done through good treatment planning. And the key here is that if you do a blind titration, that is, say, a blind assignment of some, or selection of some bite registration position, and build the appliance at some unknown position, and then blindly protrude, all of which is pretty much guesswork. If you do it that way, you're likely to end up having a good deal more interactions between your staff and the patient. And you aren't going to go in knowing that you can reliably eliminate obstructive sleep apnea. So I think it could be a great opportunity. So I'll stop there, Guy, and be available for questions.
I do think one thing that you're saying, and we have a crisis now, and I think the goal here is to get through that. I do think there's a silver lining here. I spoke with you about this, Mark, as well, that down the road we're getting more awareness because of this, and I think dental sleep's likely a way to help pull the dentist out of this this bad place that we're ending up financially because of the closure of our offices and so forth. So does anybody have questions? Do you want to do questions now? I don't see any in here. I did figure out how to open it up.
Let's save them for the end.
Yeah, we'll save them at the end there. Go on.
Yeah, maximize our time.
Absolutely.
You go ahead and switch.
Yeah, I switched on over to Mark. And, Mark, again, thank you for all the research you've done on this. It's really great to have a colleague we can go to that's put the effort in to really understand this, because there's just a lot of stuff that comes into this, and it's moving all the time. Every time I talk to you, I learn something new. So take it away. Thanks a lot.
Well, thanks. Next slide. So as we begin to talk a little bit about the reaction, I can't help but keep reflecting on this. I've got the screen up next to me. On February 27th, we had 60 confirmed cases. Now go ahead and flip. That was in the United States. I came home from Florida after 3 weeks in Florida. I had 3 lectures on 3 consecutive weekends. I had your meeting there in Clearwater. Then I went to the AASM meeting, and then I spoke at the DSM meeting. Came home on March 6th, and here we are, March 24th, 26 days later. That number has doubled 9.5 times. Today, I'm looking at the Hopkins site over here. It's 417,000 worldwide, 18,000 deaths. And compared to the traditional influenza we see, those aren't big numbers. The challenges you're going to see in a minute is how some of those hospitalizations carry out. And I've got 2 physicians here with me can talk a little bit more about that far better than I can. We're seeing jumps in numbers too because of better reporting, more testing. But when we look at Korea did such a nice job containing this. And we look at these graphs in the bottom, you can see how the U.S. is still growing on a case per day basis, where China is flattened out. You can see with the cumulative number of cases for China is going up. You can see how the U.S. is still climbing. Korea, one of the ways that they were able to calm this down, similar to China, they had a focal point of infection that they were able to kind of pounce in on and close down rather rapidly. And they've been closed for several weeks. And they were able to contain it much better. But also Korea, on a per capita basis, was doing 400 times more tests than we were. Today, we ramped up our testing capability in the United States. And that's going to help, as Fauci said today, that'll help us be able to direct some of our investigative tracking on where some of these cases are coming from and going. You can go into the next slide. This is the growth rates and the doubling rates of various countries. You can see at the bottom how South Korea, Japan, and now China have leveled off in terms of their growth rates, flattening the curve, if you will, which is fantastic. The United States, though, is still growing. The death rate's not growing quite at the same 2.5 days doubling period like we are in the number of infectious cases. And again, there's reporting a lot that goes into that. So the death rates are probably a better metric in terms of how infective the disease is, and it's probably about 3.5 days or 4 days. that's still an R naught value that's just totally unacceptable. You can see several other countries are still run ragged there, and their growth rates are, and their doubling rates are very, very rapid. Next slide.
Second.
Yeah, it's all right. So the reason that it's so discerning for us is even though a lot more people typically die, and it's only 0.1% from influenza, and they're estimating it could be around 1% or 10 times as much from this particular disease, and the numbers aren't great yet. But the type of death that you have when you have influenza, and Jagdeep, you're a pulmonologist, so you could probably speak to this far better than I could, but is a secondary bacterial pneumonia and heart attacks are the #1 causes. And the good news about secondary bacterial pneumonia is we have antibiotics for that. So we can treat them with antibiotics. And the trouble with this particular influenza is it kills you by setting up an acute respiratory distress syndrome, similar to what we saw in MERS and SARS. And because it's that kind of a respiratory distress, those folks, there is no antibacterial, antimicrobial kind of medication that we can present them with. We have to just have them tough it out and hope their bodies survive. And what we do to get them to survive is we put them on a ventilator. And so that ventilator, that's the limiting factor for us now in terms of hospitalizations, acute respiratory care, and ventilation of those patients to keep them alive long enough that some of them will recover. And so that's why our country is so susceptible, if you will, to this particular type of an onslaught. It's a very different mode and pathophysiology for how these bugs are getting at us. Jagdeep, am I on the right course here? Nod your head. Am I doing okay? I'm nervous presenting in front of a couple of physicians. Thank God John has already sworn off he's not a pulmonologist, so you've got the floor here. Scientists have told us if we could just stay put for 14 days, we'd beat the crap out of this thing. We've seen that work in some of the other countries. We're going to see that work in Italy. It's going to work in the United States. But right now, we are not shut down completely. We've got a little bit of a ways to go. Go ahead, next slide. The 158 million people, and that's when I put this slide together for you this morning. It's 167 million people in 19 states now, several counties and 3 large cities, so it's growing all the time. Roughly half the population of the United States now is locked down. I can't imagine, and kudos maybe to the administration, and I'm not getting political in any way, shape, or form, and many of you know me, know that's true. Kudos maybe to the administration. I don't know that we could have shut the country down all at once. I think that would have been an incredible kind of panic, and the rush on stores and restaurants and supplies of things, and it would have been riot in the streets. So we're kind of layering the shutting down. And I remember when San Francisco County, when the several county area went down in the Bay Area, I said to my wife, more to come. California, New York. I started looking at the data and saying which states. And as soon as New York and California were down, I said Michigan's next. I was wrong. A couple other states snuck in front of us, but Michigan was not far behind. You could just tell by the data which state is ready to make that kind of commitment, or which metropolitan area or hot spots, as Fauci would call them. Next slide. That's all good information in terms of dictating where the next closure should come. Here's the good news. We're going to get through this. We've gotten through far worse things than this. The H1N1 influenza virus of 1918, 1919 killed 675,000 Americans. Devastating to the population. We didn't have 330 million people back then, so it was even more devastating as a percentage of the population. The Wall Street crash, Germany invades France, Black Monday. I wasn't around for those first two. John, I'm sure you remember all those very well. I'm just joking. Couldn't resist that. I love you, brother. Penny, I love you. But Black Monday, the dot-com bubble. I remember Black Monday saying to my wife, oh my God, we got to do something. She goes, what are we going to do? I go, I don't know, but we got to do something. She goes, you told me we're in for the long haul. I didn't have any money in the stock to speak of back in 1987. I was 6 years out of dental school, but whatever I had in there felt like everything. The Great Recession. Look at those declines in the market, and we were up 2,000 points today. So from a market standpoint, from a recovery standpoint, from listening to what, we don't have that third piece of this puzzle together today yet, but oh my gosh, the government is going to step in. We're going to get help. Will it be enough? No, we're going to feel some horrible pain. We're going to feel some horrible pain. And so will our patients, and so will our teams. But we are going to get through this. We are going to come out the other side. It's not a time for panic. It's a time for good, concerned effort, good leadership, and good efforts on our part to guide our teams and everyone else through this. Next slide. So the government is responding. You know, we've got that first group of benefits that came through, allow for the testing, a lot of support for all the hospitals, administration, everything like that. March 18th, they passed several more initiatives that were very important to us. You've got the Family First Act, so that a lot of people can get a couple weeks worth of pay. They've expanded the unemployment benefits. They've delayed the tax payments we have to make. So you can just sense that the government recognizes the severity of the situation, that they're loosening up the kinds of things they have to allow us to get through it. Today, we don't quite have an answer. I was certain when I put the slide together this morning that we would have an answer by this afternoon, and I'd be detailing it now, but They're getting very, very close this afternoon. I'm sure by sometime tonight or late into the morning, they'll have some sort of solution where a lot of people are going to get checks and get more support, and we'll find other ways to help some of the businesses that need that as well. So the government is responding. It's not like they're sitting back with their thumbs up there. You know what? Go ahead and next slide.
Yeah, and I will mention, Mark, you put me in touch with Tim Twigg today, and
I did.
We're going to be speaking a week from today. Hopefully by then.
That's so good. So good.
I have a slide coming up, but we're going to go into detail because I've got 15 emails in my inbox with links to all this complicated stimulus and what does it mean to our employees. So tonight, I don't think we have all the information to disseminate that to everyone.
We don't.
But a week from tonight, same time, we're going to speak entirely about that. And it's thank you for the introduction, and then we'll talk about him in a little bit. But he's an HR consultant that will walk us through what this means to us in our dental practice, because they primarily only work with dental offices, and they have thousands of offices they advise. And so I think
he's not just an HR consultant. He's an HR consultant to dental practices.
Right.
So he really owns and understands. The company he owns is called Bent Erickson, and most people are familiar with them. A lot of your clients, a lot of my friends have accounts with him, and they do a great job in terms of HR. And so he is the de facto man on all this kind of stuff. Next slide.
Yep.
So we've got a lot of resources available. I wouldn't try to put them up there. My point's not to discuss them with you. I'm going to leave some things about telemedicine and such to Jagdeep to talk about. But, you know, we've got some decisions to make about what's not elective, what's not essential, what's elective therapy. We've got to figure out where something like DME provisions and where dental sleep medicine fits. I had a patient I consulted with yesterday that has a 12.7, and they wanted to kick it down the road a little bit, and I was okay with that. I had a patient this afternoon I talked to, it's a 92.7. And it's really hard to leave. As John and I were talking, there's a lot more than just the 92 for that patient, a lot of comorbidities and other things. But how do you tell that patient they're not going to get therapy? So making the decision about what kind of treatment we're going to see or not. Do we have the right resources we need? We're supposed to be able to treat any kind of an infectious patient with proper PPE and universal precautions. What can Dr. Bijwadia tell us about teledentistry, and what kind of platforms do we have that allow us to do our SOAP notes, and what are HIPAA compliant? Right now, the HIPAA rules have been suspended. You could use your iPhone, for God's sakes, but that's not going to survive the long term. And telemedicine's here to stay. It's going to get a great stronghold. Purification of air, unemployment compensation. I don't want to get into that because you're going to do that next Tuesday with Tim. That's awesome. SBA loans, other financial resources. We looked at some of our lines of credit, our HELOC. We looked at our 401k, so we have readily available literally hundreds of thousands of dollars that I could resource if we needed to, if the bottom absolutely does fall out. I don't think it will. I think we're in for a hard, 6, 8, 10, 12 weeks, and we'll come out of this. And then certainly some of the business interruption insurances, they all have viruses and pandemics like this as an exclusion, but New Jersey's fighting to maybe get that exempted. I'm not sure the insurance companies will lose that battle, but it's an interesting conversation to think that maybe it's a time in our history with some insurance companies will let down their hair and allow a few things that they didn't allow before. Last slide, please. And then finally, it's an individual decision. We'll talk more about that, I'm sure, in the Q&A section. We'll get some information forthcoming about the different platforms that Better Sleep and such can do for us in terms of teledentistry, telehealth, telemedicine. But I heard some interesting things today. Yesterday I was on a call, and a friend of mine, Jerry, who's from up in Alaska, talked about going out to the parking lot and screening patients and taking their temperature so they didn't come in if they weren't allowed to contaminate the waiting room. And I'm like, boy, I hadn't thought about that. And I work at a low enough volume that that's something I could actually do. Social distancing, universal precautions, teledeliveries. I wanted to put tele-impressions down there. Teledeliveries, I can kind of walk through that. I did a tele-repair video today for a dentist out in near Coeur d'Alene, Idaho, that most of you would know, who has a patient who had a broken arm on a Prosomnus PH. And how would we R&R that device? And so I was able to shoot her a little video and send that over today. From a delivery and a repair standpoint, easily, how could we take impressions? How could we take a bite relationship? I just don't have that in my DNA. I haven't got that figured out, but I know they've done that for Invisalign and things like that. But we've got a lot of things to think about to try and make this work so that we can still pay some of our bills, pay some of our team, help some of our patients. It's not about the money. I saw a criticism of one of my comments. Boy, it just ground my ass to a halt. And I'm sorry I said ass, but it did. It ground my ass to a halt because it is not about the money. It is about, what do I do with the 92? I want to kick the 12.7 down the road. I want to treat them later. Jagdeep, you and I have talked about temporary devices, other options. I'm sure you'll mention some of that. Great ideas. But what do I do with that 92? I can't leave that person out of treatment. I got to get them into a temporary device. Can they make that at home? I've got to take impressions. I got to do something for that patient. That's kind of my sworn duty as a healthcare provider. So that's where I'm coming from. Jagdeep, I'm handing off to you. Thank you, brother.
Yeah, and we're going to
Thank
get we're going to have enough time for some questions, because I think, Mark, one of the key things that's coming up was we talked to our members and different people is, the state says one thing, what is essential health care, how are we making these decisions? And I think I'd like to save that for the Q&A. I think
Totally.
at this point, we have regulations set by your individual states. We have the ADA recommendations. We have the mandates by the state. But here in Florida, I'll just leave this out there and we'll talk about it in a little bit. Florida, they said all unessential health care. And I've gotten opinions from healthcare attorneys. I've talked to my sleep physicians in this area. And
what did they tell you? What did they tell you, Guy?
It's up to you to decide that. Basically, I mean, what would you do? Can you justify what you're doing? Does it make sense? The AHI of 92, if that was my brother or father or someone, I would come in and get them a device, and and I would practice universal precaution. The healthcare attorney told us that he felt that would. Now, attorneys won't ever tell you, hey, that's legal, that's not. They say it sounds like you have a good argument here for your favor. If you
I could defend that.
I could defend that. That's the way they said. And then I talked to the Sarasota Sleep Lab is currently still open. They're not doing titrations, but they haven't totally shut the doors. And one of the sleep doctors I work with in Sarasota, he's still seeing sleep apnea patients, and we're doing everything by telemedicine that we can, by phones and so forth, and then deliveries and on the more severe patients, and even if they're ready to come in and get scanned, we're going to go ahead and see them. And I feel that that is within my interpretation, my attorney's interpretation. The patient is understands the risk. We've gone over all that with our team and said, you don't have to come in here. This is not a mandate. And we've all weighed all that, and we're seeing the patients in person that we absolutely have to. We consider that, and then the rest of the things we're doing over the phone. And so I think there'll be more questions about that in a minute, but I know that's really one of the most common things we're getting at Dental Sleep Solutions as far as what do we do here. My state says I can't do this, and I think you really got to read what they say and see if what you're doing fits underneath the guidelines of like in here in Florida, it's essential care. So, all right, Jagdeep, we've got some time for you to go over this, and everyone. I think I can view the questions now. Sorry for my technical difficulties earlier. It's the internet's really been lagging here. I think it's part of it with all the bandwidth everybody's using. I think I'll at least blame it on that. Let me get away with that one tonight. But I got the questions now, and we'll get to them at the end here. So take it away.
Right. Sounds good. So my name is Jagdeep Bijwadia, and I'm a pulmonary and sleep physician. And it turns out that I've actually been involved with promoting telemedicine, especially as it applies to the collaboration with dentists for, well, at least 2 years now. And so it's sort of an interesting time for me. And I think one of the things that people probably haven't realized as much is that telemedicine involves thinking through quite a few things. So it's easy enough to pick up, for example, a cell phone and have a FaceTime with the patient. But then there's so much more to it. Where are you going to document your findings? How are you going to order a test? How is that test result going to come back? How are you going to communicate it back to your patient? How does the whole workflow happen? And I think that those are things that we have in place today that I think are quite advantageous. And I think that what will happen, and I agree with what everybody said, that right now there's a lot of people that are not practicing in their offices. So can we use telemedicine? Yeah, for the few people who see. But when the doors open up, right, and people start coming back, whether in large numbers, I think telemedicine is here to stay. And I think that this is going to take the field of telemedicine forward by 5 years, is my guess. So just jump on to the next slide. So it all started when CMS, flexed its muscle and said, the rules for telemedicine are relaxed. And I must say that was such a smart and really important decision, because not only for dentistry, for all of medicine in general, right? Because all of a sudden now, I'm not abandoning my patients when I'm home. Today, I was seeing patients from 8:30 this morning till 5 o'clock this evening, right on my computer right here. And it allows us to do that in a very seamless fashion. So kudos to CMS, kudos to the current administration. I really think that was a good decision. And other payers are following suit. So Blue Cross Blue Shield, United, Aetna, everybody is pretty much saying the same thing, that hey, if you are seeing your patients by telemedicine, we'll pay you the normal rates. So that's very encouraging. Moving forward. So what are the benefits of telemedicine? I mean, outside of this epidemic or a pandemic, it just creates value for payers, consumers, and providers. As something, I can't tell you how many patients I saw today that says, hey, doc, maybe I should just do it this way, and they say it laughingly, but I do think that it could be a paradigm for the future, because it is less expensive. It increases the access for consumers. We can reach a lot more patients sitting in the comfort of our homes. Certainly a reduced cost structure, much less overhead for the physicians, obviously, and dentists that will practice this, and incredibly high customer satisfaction. Like I said today, it was amazing to me, because I was just sort of interviewing my patients as we went, and I said, did this feel comfortable? I mean, this is the first time you've ever done this. He said, absolutely. It's easy. Especially, and I'll put a little plug in for sleep medicine and sleep dentistry. It is so easy to do a physical exam. I mean, I ask the patient to lean towards the camera, open their mouth. I can do a malanpati. I can look at their tongue, see if they have an overbite or an underbite, right? Mark, thanks for demonstrating right there. But it is it's a really sleep medicine lends itself very well to telemedicine. So next slide. So I think that, in terms of must-haves, obviously patient consent and privacy. And by privacy, I mean, when we do telemedicine, we want to make sure that there's not other people in the room around us, and, the patients feel a sense of, that they're in a private conversation with their physician. I think that's important. We really should be following the same standards of care as in person. And especially for sleep medicine, again, I will tell you that there's really no difference between what I do with a patient in my office versus what I do online. You should have an electronic medical record so that you can, document your findings and your conversations as you go. There's no need to store video or anything like that. There's absolutely no rules around that. But you should have clinical protocols and contingency instructions, and a very well-defined workflow. So moving forward. So I think the American Academy of Sleep Medicine, again, much prior to this epidemic, this was in, I think 2015, if I'm not mistaken, said, we support the use of telemedicine, and they have a position paper that is very detailed in terms of what the requirements are, what kind of exam you should have, what kinds of patients you can see. And, pretty much there's a very few instances in sleep where you actually need a polysomnogram, maybe for the for the parasomnia, seizure disorders, things like that, narcolepsy. But beyond that, I think most moving forward. So we've been thinking about this again for the last 2 years, and we've created this company called Virtue Sleep that basically is trying to eliminate barriers for dentists. And again, remember, this was much before the pandemic. So we thought that, hey, if a dentist identifies a patient in their office, why do we have to send that patient to, another office, do an in-lab sleep test, shuttle back and forth? Let's just get them, through our process, and usually within 14 days, they can come back with all of the required documentation, sleep studies, results, and, move on to a dental device. So we want to, we've always wanted to focus on patient choice and keeping the patient costs down, and keeping the workflow very easy for the dentist as well. And I think one of the real important pieces of work that we've done is to try and create a workflow that can be tracked on the dentist side. So when you refer patients to us, it's very visible to you what's happening with your patient population. How many of them went through a consult? How many of them actually got a home sleep test? How many are coming back with an RX, for example? Moving forward. Next slide. So Virtue Sleep essentially is a partnership between a telemedicine software, which is called Doctor Web, SleepMedRx, which is really a network of physicians and nurse practitioners, and a home sleep testing company called VirtuOx. So it's a seamless pathway with that partnership to get a patient right from the chair into oral appliance therapy or CPAP for that matter. Moving forward, I'm going to go rapidly through the next few slides just in the interest of time because I want to leave time for consults. We've gone through a lot of this before. We have a secure platform. We could do telemedicine. We can do, we eliminate multiple visits. There's updates for the dentists. There's a chain of custody testing if we have DOT patients. And it's a very fast and efficient turnaround time. Next slide. So taking you through a really rapid look at how the patient experience goes. So if a patient's at risk for obstructive sleep apnea, they're simply referred into our program. It could be at the front desk as they're leaving your office ideally. In these circumstances, maybe they just get an email link to our website. Moving forward. Next slide. They'll come to this screen where they just simply sign up, as you can see, for the consult. Next slide. Once they sign up, they'll get an inbox email saying, "Hey, welcome to Dr. Webb. Register and activate your account." Next slide. Once they do that, they go back and they simply schedule an appointment. There's a tab that says "Schedule an appointment." Next slide. You can book an appointment with a sleep medicine specialist or a pulmonary medicine specialist. Right now, we're concentrating on sleep. Once they do that, they can see a list of the physicians in their own state or nurse practitioners that they can click a button and make an appointment. There's a whole schedule there. You just click on whatever time is convenient for the patient. Next slide. The patient then, on the day of the consult, prepares. They get a text saying, "Hey, be ready for your consult. It's in the next hour." Next slide. They would connect just like you do with FaceTime. The providers can write clinical notes right as while they're talking to the patient. And we order the home sleep test right after the consultation on our platform. And so on one side of our screen is the patient's video, and on the other side of our screen is the EMR. So we write and we order tests just as we go along. Next step. Next slide. Lastly, once the home sleep testing is ordered, it's like many home sleep tests that all of you use. The device is mailed to the patient's home, mailed back, and uploaded into our portal. Next slide. Once the study is completed, all of this can be seen right on your website, on your dashboard. So you can download our consult, you can download the home sleep study, and our RX, or the prescription. And once you have all of that, you're ready to fit your device and bill for it as we go. And typically our turnaround times are in the range of 2 to 3 weeks for the whole process to be finished, as long as the patient is cooperative. Next slide. So this is just an example of the dashboard that you may see on your end, so you know how many consults are done, how many home sleep tests, etc. So you can monitor these patients very closely as you go through this process. Next step. Next slide. So this is just a picture of the physicians and nurse practitioners we have. We're all board certified in sleep. On the left-hand side is Kyle Michael, the founder of Virtuox. They're our partner for home sleep testing. We really use a variety of devices. It could be the Night One, it could be an Apnea link, it could be a WatchPad, depending on the state and what specifically is ordered. So we're really device agnostic. We don't care. We just want to get the patient tested in an appropriate and efficient fashion. Next slide. You can see that we cover all 50 states. Some 50 states in green have several providers. Some have 2 or 3 providers, depending. But right now, all 50 states have coverage through Virtual Sleep. So it doesn't matter where you are. We can provide the service for you. Next slide. So I think one of the interesting things that's going on right now is discussions about home sleep testing and how safe are they, and are the belts okay, and how do you sanitize them. And I thought I would just, as advances happen in medicine, we just have a little new device called the EctoSense, which you can see is about the size of this little button that goes on the finger. Very, very easy to disinfect, very easy to clean. It goes back and forth and gives you an AHI just like the WatchPad does. It works on peripheral artery constriction as the apneas occur. So it's very accurate. We just had it FDA approved. So this is another, I'll say a tool in our bucket as we start dealing with more patients and start worrying more about the ability to keep things sanitized and clean.
Yep.
Next slide.
Yeah, I've used that. It's very, very cool.
Yep. So for that, that's just a quick review. I just wanted to sort of mention that we've been around before this. I think that it's important for us to know how the workflow occurs. And if anybody wants more information or to sign up for any of our services, we certainly have it. We want to help, especially in times like this. You can use this platform, by the way, to see your dental patients and be able to document and use this platform to interact with your own patients as well. So I'd let you know that. And we really, at this time, it's really about how can we help the most people right now. So I'll turn it back to you, Guy.
Yeah, sure. The next webinar, I'll come back to that in just a few moments, but it's a week from today. And just to give you the high-level overview, we're going to talk with Tim Twigg. Again, I'm very impressed with him. Thanks, Mark, again for the introduction. He's going to go into detail about what the stimulus packages are, what it means for our employees. Do we lay them off? Do we do vacation? How we deal? How do we tap into this money? What's the best ways, and even some state regulations. So I want to pause here because I think, this is a subject, Mark, you and I talked to a smaller group last week about. We had a lot of questions. I think I figured out what was wrong with my question. Are you all seeing all this now too, like you were before, Mark?
I am not anymore.
Okay, good. I think it was the lag in the, there it went away again on me. My gosh. I think it had something to do with the internet cutting out on me. Now I had it and it was gone. So someone who can see the questions, do we have some questions? Because I literally had it and then it was gone again here. So
Brandy, can you see any of them?
I do not see any. Lisa, do you? I haven't seen any that have come through.
Okay.
No, none. There aren't any that have come through.
Well, I think you all might have some if we. I think the thing I'd like to talk about a little bit more is, we've got some high level things here. What are we doing tomorrow? And I think that's what the questions are. What are we doing tomorrow? What are we doing 2 months from now? What are we going to do different in the future? And Mark and I have had many discussions about this. Jack Deep, we talked about it. I think you have to make a personal decision as to what. I just got a text. There's nowhere to type in the question, so I don't know what's funking going on with the go to webinar this time. So apologize. What we might be able to do.
How about if they text me the questions or something like that? Would that be all right?
That'd be fine. You want to give your number there?
24. Everybody write down this phone number: 248-561-9951. That number again for your texting pleasure is 248-561-9951. So there's a question that popped up almost instantly for you, Jagdeep. How does telemedicine do some of the vital signs?
Right. So we actually ask the patients their height, weight, and neck circumference, and then we do an upper airway exam. And that again is exactly following the AASM telemedicine guidelines that have been provided. So sometimes, if the patient, we suspect there are other things, we might look at their hands and see if they have cyanosis. We can look at their feet and see if they have edema, but that's sort of rare. I think in the most common circumstance, we'd ask those basic vital signs.
Okay. What do you think about billing? How is the how is billing going for telemedicine and dentistry? And I'm going to answer part of that. The ADA has some guidelines. I can send those around when we're done, so that for dental teleconsultations, forget about sleep medicine for a second. For dental periodic exams and emergency exams, et cetera, things like that you might do by telemedicine, there are codes. And there are G codes that you apply, and you get paid your regular kind of an exam fees based on time and everything like that. So, Jagdeep, what about for the medicine side? How does that work?
Sure. I think for the medicine side, it's similar. So we use what's called the 9-5 codes or the G codes for telemedicine consults. We typically bill by time rather than complexity. But we bill this exact same codes as we do when we see patients in the office, and get reimbursed, by the way, exactly the same. Now, this only applies to places where you have in-network contracts. So in Minnesota, where my practice is, we can do that. But if I was seeing a patient, for example, in Alaska today or Washington, we would have a cash pay basis for that.
Here's a really solid question that I think the whole panel can answer. In this particular dentist state, it really doesn't matter what state. He's got New York State down here, but it's like, again, it's not important. we can only do emergency care. And I think most states have used
That's
the
right.
terms emergency and essential care. That's what we've got in Michigan as well. Is dental sleep medicine emergency? And I don't know. I can think of some circumstances under which it'd be emergency for me, but I do think it's essential treatment for certain patients. And I spoke about kicking the can down the road a little bit for a mild patient, but not for a severe patient. And I used the example of a 92, pretty extreme, but just happened to me today. So what does the rest of the panel think in terms of seeing patients?
Yeah, I think that's the number one question we've been getting. And I'll start by saying, we have our own opinions, and you have to have your own opinions. We don't have the answer. I can't say here's black and white. I did talk to my healthcare. He's a board certified healthcare attorney. I asked him that question, and I posed it in such a way. I said, someone who has moderate to severe apnea, do we see them as that essential to go ahead and either do impressions or deliver their device? If we're doing everything that's non-essential that we can do otherwise, we're doing all of our consults now by phone. We're doing them, and I think one thing you mentioned too, I want to take a little aside here, is if you're doing this from your house, that means you're not sitting in front of your family talking about patients. You got to go in a room. We had a big discussion about that. If you're sheltered at home, you've got to be careful about talking to your patients and violating HIPAA while you're sitting in your living room with your family there. So, but anyway, we're doing all those appointments at home, not at home rather, but over the phone, and we're seeing the patients for what we have to, impressions, which we do scans and deliveries, and if they're having a problem, and we have to use a judgment. Like you said, for the more severe apnea, I posed that to our healthcare attorney, and he felt that he could. What'd you say, Mark? Is probably what he said. He said he could defend
essential treatment.
Yeah. He said that under the heading of essential treatment, he felt you could defend that, and that sounded reasonable to him. I think it comes down to a saying that I say jokingly, but it's true. Breathing's important. So if we had a crystal ball, we knew that was the person who was going to get the virus, and maybe having a mandibular advancement device may help them. We don't know this. Maybe it's right for them. We don't want to just justify it either. I'm not going to, I got someone who's a snorer and AHI of 6. We're going to see them later. So you have to make your own decisions on that. I talked to the sleep physician in our area. He still has the same attitude that we do about it. His sleep center is still open for certain circumstances. Jagdeep, I think you said yours are closed though. Is that up in your area? Is that correct?
Yeah. Most sleep centers are closed in Minnesota. I think you're right. We all have our personal sort of perspectives on this. As a sleep physician, I have to say that I can think of only very few circumstances where I think treatment could be considered emergent. For example, if somebody is driving, and feeling drowsy while driving, or is, on a big rig and start, sure, those are patients where I feel like there's danger to the patient, to himself, as well as to the public. But I will say that those instances are pretty few and far between. So I feel like sleep apnea is something that most people have had for weeks and years. And I think if we can be patient and maybe temporize with a temporary device or something in the meanwhile, to me it seems that maybe we should be more circumspect about trying to figure out these things. John, I'm interested in your perspective.
So can you hear me? I'm practicing in basically the same situation has been described here. A few comments. One is for me as a sleep physician and one who's very interested in pulmonology, I have a strong feeling that what really counts is how much the oxygen goes down. and so there have been patients in my career where I've almost taken them by the hand and walked them straight over to the CPAP provider and said, now, put that mask on right now, and I don't want you to sleep one more night without a good therapy. So those are extreme, but they happen. But in general, I think severe sleep apnea, particularly any sleep apnea associated with severe oxyhemoglobin desaturation, and I'm talking down into the 70s or 60s and so on, will if we're not going to give them CPAP, which we're probably not right now, then I think rather expeditious therapy with oral appliances is justified, important, and I would say that while you could slap a temporary appliance in there, or whatever you want, trial appliance, and protrude it out to some level and hope for the best, I'm still in favor of wherever possible, not compromising the quality of care. So I want the very best treatment that's equivalent to the CPAP in oral appliance therapy. So that's I would very much go err on the side of saying this is if you judge it to be a severe case or moderate case, and you have really a good evidence for a drop in oxygen, I'm in favor of proceeding. It's a judgment call. You may wait till the crisis goes down a bit, but we're going to be faced with this, not only in the next few weeks, but in the next few months, I feel. So I'm in favor of everything that's been said here.
Let me point out one other thing that Mark pointed out to me, or we discussed together, is, and the attorney that I spoke with agreed with this as well. Even though we're dentists, we're doing a medical procedure. We bill medical.
Right.
And I said, should we go by the medical standards or should we go by the dental standards for this? And he felt we would be more held towards the medical standards. So we should look at what our medical colleagues are doing, not dentistry.
Oh, yeah.
We're doing nothing like dentistry. We're not high speeds. We're not blowing, cavitrons around the room. We're not doing any of those things. The reason they specifically call out dentistry in these governor's orders are because of the health risks similar to the CPAP as far as expelling the germs throughout the office. We're not doing any of that. So I think if you want to look for guidance, think about what the medical colleagues, that's why we called some of our sleep physicians today and yesterday to kind of see what they were doing, because we feel we're more aligned with them than calling my dental colleague down the road.
Great point. Great point, Guy. This is a medical disease. You're the therapist of for the medical disease obstructive sleep apnea.
Right.
And so I find you must position yourself within that scope and that sphere, not a dental sphere.
Right.
So what you're doing, you're a dentist, but you're not treating the teeth.
Right.
You're treating a medical disease, folks, and so think of it that way, and I think you'll be in good shape.
Yeah, and again, you have to make your own decision. One thing I want to mention too is I told my whole team, in writing and in person, I didn't just tell them, we discussed this. Look, you have to make your own choices here. No one's saying come in to see the patients. There's your choice whether you want to continue to come into the office or not. And the ones that are there all chose to do so with no pressure. We can't. What you don't want to do is say we're going to make this decision and then tell your team they have to do it.
We've got a couple questions here. Brandon, that was for you, brother. Thank you. Brandon was making fun of me because I kept pointing to my phone. So somebody asked, we were talking about teledeliveries. Somebody asked if, because I did one today, would we provide some more videos that will help with teledelivery? I think we could certainly do that. Teledelivery is one tool that we have available to us. And so yes, creating some sort of a video that helps guide the patient through that is important. But I think I'd still want to do that with a telemedicine visit, and I'd want to have them on Facebook or something like that to kind of walk them and guide them through that at the time, so that if they got it stuck or were having difficulty seating it in, I could see what was actually happening. I wouldn't want to relegate that completely to just a video. Somebody else here asked a question. I've got about 30 questions. They're popping up faster than we're going to have time to answer. They got an email from a couple of the sleep device manufacturers today saying that there was going to be some delays in deliveries, some closure of some operational facilities, things like that. And they could see my shirt and ask what happens, what about personas? So we're in the Bay Area, so we were the first area in the country to lock down with a shelter at home. But because we're an essential medical device, class 2 medical device manufacturer, we certainly are able to keep open. So that's not a problem at all. And we still have capacity and everything like that. I would reach out to your sales rep to talk about any issues or question you have, but we have capacity. There's no question about that. And we're full operational. And I think it's going to be tough for some of the dental laboratories that are also laboratories and device manufacturers. That's going to be a challenge. Is there documentation to support that we can get paid from telemedicine for dentists getting paid for telemedicine? And I'd say the answer is, what I've heard is yes, that we can get paid from that, that's not a problem, and as well as for teledentistry. And I would just, I think all the rules are going to be somewhat relaxed that we see right now, and so we're going to get a break on that.
Right.
TMD screening, palpation, is part of the exam that we do from a dental perspective. I think when you're doing your telemedicine visit, Jagdeep, you're probably not likely to do much of a temporal joint exam or palpation. It's not really in your arena to speak of.
Right.
But for us as a dentist, what would, and Guy, I'd have my opinion on this too, but John and Jagdeep, what would you think about, what about some of the more detailed parts of a dental examination that we might normally do? Now, if it's your own patient, if you're a dentist seeing your own patients, you've probably already done that or should have already done that. For me, I don't have any of my own patients. I'm only seeing referrals coming in either from a sleep physician or an occasional another dentist. So what would you say about that? You know, there's some things that we're not going to do. There's some things you're not going to be able to do in the exam. Is it okay to do 75 or 85% of it by telemedicine? Would that be relaxed enough at this time? Do you think we could get away with that?
Again, there's not a yes or no answer. You have to be comfortable with what you're doing. The guy's just had a heart attack and has an AHI of 75 and he's going down into the 70s. You talk to him over the phone, say he goes to the dentist regularly. He's got good teeth. He doesn't have any pain. His joint never has. You can have him open and close on the, on the televisit consult. So it's fine. You can see him. We did a consult. My partner, Justin, did a consult yesterday. And it really paid off that we did it via phone because the guy had AHI of 75. Okay, well, gosh, he needs help. But he's wearing his CPAP every night, so he's compliant, and he has dentures. And so we figured that out over the phone before he came in, so he's really not a good candidate to come in. So we saved that in-patient interaction. We are screening our patients for COVID-19. They're filling out a questionnaire before they come in. We're discussing it with them. We're only seeing one patient at a time. We're wearing all the personal protective equipment. We're spraying everything down in the reception room and everywhere when they leave. And so, I mean, we have some protocols in place that's actually on our website, what we're doing now, just in this interim. If you're comfortable doing that for the patients that you feel you need to do, then do it. If you don't, then you just have to really make the decision per office, per patient. We're seeing a whole heck of a lot less people. It might be financially a better decision to shut the door, to be honest with you, depending on what Tim tells us next week, but that's not the reason. That's not the reason we're doing it.
Mm-hmm.
Guy, I wanted to make a quick point that when you start thinking about should I do should this patient be treated or not? Is it urgent? Is it an emergency? I think it's really important to remember that this is a team sport, right? Pick up the phone and talk to the physician that referred the patient.
Good point.
And say, like, hey, what would you do? I think that would be an important thing to do.
And I don't think any of this is
exactly one of the questions, Jake. So I think that's a great comment. They said, shouldn't we check with our physician and see how emergent? Love it. That was great. That was one of the questions I was going to ask.
Yeah, and it's not emergent. It's emergent. In Florida, it says emergent or essential care. I don't, so I think the essential care is, to me, that's where it's a little more vague. And, so we're worried about getting ourselves infected. We're worried about infecting the patient. We're worried about getting possibly sued for doing this or being in trouble. I guess you could think of it, you can worry yourself to death about anything that you want. What about if we don't see that patient? And, I don't know about you all, but you've heard me talk. I have a personal story of someone I knew that we had a conversation. A couple of days later, they died in their sleep of apnea. Actually, I know another patient that we made a device for. The ER physician, one of our members made him the device. He took a nap in his car because he got a new truck and he loved his new truck. And he was sleeping. He's on call. He died in his truck in his sleep because he didn't put his device in because it was in the other room. So was that, I have real stories where that I feel that the not treating apnea has led to an acute event that someone died from. we weigh all those things out in our head and just try to do the right thing. If you're doing it for the patients, I think that's the key, and you have to make your own decisions. It's not black and white. I think that's the bottom line on this. You have to, if you want to stay in the house and see none of these patients, no one would fault you for that either.
So Guy, if we could put up a slide, if you could make one real quick or something, or maybe they're on the beginning of all those other slides, if you could just conglomerate them, where everybody's email's available, and we could send out the ADA billing codes, we could send out the American Academy of Sleep Medicine, the medical billing codes, we could send out a copy of these slides, anything anybody wants, they could contact your team for that,
yeah.
I'm sure.
Yeah, they can certainly contact us, and I can, anything else you want me to put in that, we can certainly forward that. Just info@dentalsleepsolutions.com. I don't have a slide I didn't even make one here today because let's see here. I can do that real quick, but I apologize to everyone for the. I think we've had a lot of.
It was wonderful of you to throw this together as quickly as we have. Everything's fluid and changing all the time. Awesome job.
I see. I can do that, but it's we've had a lot of problems with all kinds of technology lately because I think everybody's using it. And here we go. Can you all see that?
While we're doing that, Karstensen wrote in Washington State, the sleep docs are closed. Okay. So that's kind of interesting. So that's why you have to look at this on a state-by-state basis. It's an individual decision, and it's never going to be very easy for anyone to make those decisions. I think for me, it was clear cut when I'm thinking about the 12 and I'm thinking about the 92. I've got a couple of bookends to compare to. Yep. And just like you said, for somebody in the middle, it's going to be a lot more challenging.
Yeah. Sure. Yep. Yep. And then again, I want to emphasize there's our contact. If when I was talking to Mark earlier today, this is for sure a hour in and of itself. Is if you're going to close and your team has to stay at home, do we have to pay them? Is it on us to shoulder that? Is there government money available? How's the best way to handle it? So we put everybody to part-time, or do we, Mark, you and I talked about maybe we're better off to let some people go and keep the other ones so that they can collect unemployment.
We are.
What are these new rules about the government reimbursing us and giving us tax credit? I'm really excited about this because hopefully Tim's going to break that down into what we need to do and what we can do, because I just keep getting information from this daily. And you personally know Tim, and I've just recently met him, and I know he's going to do a fantastic job of breaking all this information. If you are on this, if you got signed up for this webinar, you will get a invitation to this webinar, which is a week from tonight. I hope to have less GoToWebinar problems. Again, apologize to everybody about that. I do think it was on their end because I've never seen something like that before. So anything you want to comment on him, Mark, before we get to any other questions?
No, he's extremely knowledgeable. I've come in contact with him with talking about HR issues in regular dental offices. And I noticed that he just did a webinar the other day talking about some of the particular issues that are unique to this COVID-19 pandemic that we have right now. And so you and I got to talking, and I said, Guy, somebody's got to have this guy on. And so I reached out to him, you connected with him, and so thank you for following up on that. I think he's going to be a tremendous resource. He loves dentistry, cares about our profession, and I'm sure if you have a conversation beforehand, he'll understand whatever small peculiarities there might be about dental sleep practice instead of traditional dentistry.
All right. Well, again, if you have any more questions, just email us there, and we will get you copies of these slides. Mark will send me some information you might feel is pertinent. We can forward that on. Thank you, everyone, for attending, and thank the three of you and Mark for pulling us all together. What a great crew. It's always enjoyable to talk to each of you.
I'll answer the rest of you too.
Okay.
Good. Thank you.
Yes, thanks everyone, and be safe, and we'll get through this together.
Thank you.
All right.
Bye-bye.
Bye-bye.